time, I want to welcome and acknowledge the people who are joining this community and this inner circle session for the first time. So any one of you who is here for the first time, please let me know your name and location. Well, I see a lot of regular here today. Yes, great. Dr. Sri Harsha, let us know your name and location, please. So today's topic is going to be very interesting, where we are going to discuss regarding pterygoid and zygomatic implants, and a lot of tricks I will share with you along with down solving for it. How many of you have attended at least 50% of the inner circle sessions? Just type me in the comment box, please. Anyone in this group attended more than 5 of inner circle webinars? Dr. Sri Harsha is telling 3. Dr. Kalpana is saying 5. Right? So iPhone Red is 3. So which of the till other people are joining, just wanted a quick review. So Dr. Anil is saying 4 webinars. So among the webinars attended, which was your favorite webinar so far? Dr. Sri Harsha, Dr. Kalpana, iPhone, Dr. Anil Kumar, which was your favorite webinar so far? So till people are typing the answers, let me tell you, so far in the inner circle premium group, in the past few days, we have covered this topic with Dr. Sumit Agrawal, who has taken the pain to put up a video and solve the queries. Along with that, in the inner circle premium group, the impression technique and the note impression technique has been discussed in detail. So those of you who are keen on having a 24/7 action, you are also welcome to think about joining the inner circle premium. My staff is putting the link to the inner circle premium group right now in the chat box. So those of you who are keen on joining the premium group, where continuously we are discussing this kind of activities, you are welcome to join. So as mentioned before, the inner circle members get the privilege to start asking their questions on this today's class, which is the zygomatic and pterygoid. And of course, when things get lined up, streamed up, we will also give opportunity to those who have taken the effort to join us today to also ask their queries. So Dr. Kalpana is sharing that you enjoyed the pterygoid lecture. Thank you, madam. And iPhone enjoyed now bypass. That's great. So all of you have some experience regarding this webinar and how the process goes. Hello. Anyone joining for the first time, just acknowledge yourself, please, in the group. Anyone new in this community, just wait for another 1 or 2 minutes. Dr. Rajesh Jaskar, welcome to the community.
Minimum 50.
Dr. Shrikant, great, welcome. Yes, so you have seen Dr. Reach. Great. Dr. Mithilesh Solanki, nice to see you. Dr. Sumay is, I think, trying to log in. So, a lot of familiar faces in. Now, how many of you have attempted, I'm using the word attempted, pterygoid implants, and what is your probable success rate? So, let's say you have attempted 10 pterygoid implants. What is your success rate? 3, 5, 10 on 10? And how many of you feel you can do it predictably, or you feel there is some difficulty in doing it? Just quickly, if I want, so that I can understand what is the overall, these people who are here, what is the overall wavelength of everyone, so I come to know. So Amit Jain is saying 7 of 10. That's a very nice number, Dr. Amit. Keep it up. Hopefully after this webinar, you will make it 10 on 10. Anyone else who has attempted the pterygoid implant? And what's the average hit ratio? Means if you do it 10 times, how many times you are able to successfully do it? 3, 4, 5, 6, 7, please let me know. Yeah. So Sriharsha is saying 6, great. What I have normally seen is doctors who are interactive, pay attention during the webinar, automatically their queries, their doubts start reducing. Otherwise, I've seen a lot of times doctors unfortunately are trying to multitask and then the same information they are seeking. So if you can just focus on the next 1.5 hour, whatever, lot of your queries related to this vast topics will get covered. So is it good for me to assume that no one else in this group has attempted pterygoid implants and only 2 people have attempted, and out of which they have around 60 to 70% success rate? After Srikanth is saying 4, okay. It's okay if you're not getting. Dr. Kalpana is saying 3 times, okay. So one missed, okay. Dr. Srikanth, 50-50, okay. I have attempted, success rate 70%, great. So that's like a nice way of reviewing yourself. Okay, Dr. Anumant is saying not predictable, okay. So you're attempting, but you're not sure that whether it will happen, not happen, till it happens. So it's not predictable. So doctors who have just joined in, we are discussing, and I'm asking you if you have attempted pterygoid implants, and if you have attempted it, probably what is your success ratio? So if you have, out of 10, if you have got it 3 times, that means your success ratio is 30% or 3 on 10. So those who are just joined in, if you can, hello, Dr. Jyoti Nayak has just joined. So, right. So just you can put up your success rate. Okay, just let me know the success rate quickly, and we'll start taking up questions from the inner circle premium group first. So premium group, any of you are there in the premium group, you have the privilege to put in your questions first. Answers first, I think the question from Dr. Ankur Srivastava. So Dr. Ankur is asking, so all of you, I request you to pay attention now for the next 1.5 hour, because this is a very vast topic and we'll be able to cover up more points so that, the repetition is not needed. If those of you who are here, you can, devote this next half an hour, 45 minutes and pay good attention. I think it will really help you so that your filtering process, how to screen for the pterygoid implants, what landmarks you need, and what are the probable errors you make and how you can eliminate them, all those will get clear. So are we ready to go? Just let me know ready in the comment box so we can start taking the first question from Ankur. Are you all set for it? Are we good to go? Please let me know ready. So if you're all good to go, am I audible properly? And you're all settled, please let me know so we can start by taking the questions. So we don't, yeah. Thank you, Dr. Sandeep, for confirming. The first question is by Dr. Sri Ankur. Dr. Ankur is saying, the radiographic landmarks of pterygoid implant in the opinion. Okay.
देखिए दाढ़ का 500 रहता है और यदि अकड़ दाल रहती है यदि तो उसका ज्यादा रहता है सर। हाँ तो फिर 500 रहेगा और अकड़ दाढ़ रही तो ज्यादा रहेगा, मैं ये बता रहा हूँ।
So let me just pull out one OPG X-ray so we can discuss. Let me show. Am I audible to all? Just okay. Just let me know if I'm audible to all. So let me show you the relevant anatomy first. Is my screen visible to all? Just confirm it, please. Yeah, is my screen visible? Great. Okay. So as you see here, if you're looking at the maxilla, the most important structures which you need to know, and these are probably the only structures you need to know, is the maxilla itself. So we are looking at an occlusal view. So if the patient is on the chair and he has opened the mouth, this is how we are going to see the structures over here. Okay. So what we need to understand is, this is the maxillary bone. This is the alveolus. This part is the alveolus. That is where the teeth are attached. This is the hard palate. This is the hard palate. The yellowish bone which you see is your palatine bone. You see this butterfly-like bone? This is called as the palatine bone. So a lot of times when you are placing your implant through the palatal root of 7 in an extraction socket, you may end up hitting the palatine bone. How many of you were aware of this palatine bone? Please let me know aware. Or if you are not aware, you can just say not aware in the comment box. I request all of you to be interactive so that this session will be more fun. Great. So a lot of people are aware. Thank you, Dr. Sandeep, Dr. Mandar, for confirming that you were aware of this structure. And you also have the lateral pterygoid plate and the medial pterygoid plate. These both are structures or part of your sphenoid bone. Now this medial and lateral pterygoid plate fuse with the distal part of the maxilla to form what is called as the fusion zone. So this area over here where the medial and lateral pterygoid plate fuse with the distal part of the maxilla, this is called as the fusion zone. This fusion zone is roughly 14 millimeter in length and 4 to 5 millimeter in width. Is this clear to all so far? This fusion zone is roughly 14 millimeter in length. So if I look at the length of fusion over here, this 14 millimeters, this is the length where the distal part of the maxilla fuses with the medial and lateral pterygoid plate, and this area is called as the fusion zone. So you can see the lateral pterygoid plate. Inside you will have the medial pterygoid plate. If you look at this right now, if you look at this structure right now, you can see here clearly. This is the medial pterygoid plate. This is the lateral pterygoid plate fusing with the distal part of maxilla. You can see the what is marked in blue is the fusion zone. Has everyone understood what is the fusion zone? Because next part is very important to understand how to get there. So unless you understood the anatomical part, it will become difficult for you to understand the next part. So has every one of you understood the fusion zone? Please let me know. Just type yes in the comment box if you understood and we can go ahead. Thank you. Thank you for confirming. Now, anywhere on this fusion zone, if you place your implant, you will end up placing your pterygoid implant. So if you see here right now, you can see the implant, whether it's a conventional implant or basal implant, it has penetrated the fusion zone, and if you see carefully, you can see the tip of the implant exiting the fusion zone. You can see the tip of the implant exiting the fusion zone. Now just remember that this is your end point. I have seen myself on a lot of webinars and YouTube videos. Some doctors recommend going beyond the fusion zone and continuing further to hit the medial pterygoid plate. That is absolutely not needed, because that is where the attachment of medial pterygoid muscles is, and you don't want to engage any muscle. So I hope you understand the fact that the direction of this implant will be buccopalatal, superiorly traveling distally, but we intend to stop at the fusion zone. Is this clear to all of you? So direction, you can note it down, will be buccopalatal, as if you are doing endo of the upper third molar. The end point remains the fusion zone, which we just discussed a minute back. And we don't need to go beyond this and engage the medial pterygoid plate. Is this clear so far? Super clear. This is what we want to do. This is what we want to do. Is this much clear to you? Please let me know, please. Great, great. Good to know it's getting clear. Just request all of you to just pay attention so that everything will become very clear to you, and no longer you may have to keep hunting for things anywhere else. Now, one of the most important instrument to reach the fusion zone is your C finder. But before we discuss how to use the C finder, what Dr. Ankur has asked, let me come to that point, is how to identify the fusion zone on the X-ray. So please pay attention so that now we can discuss how to predictably find the fusion zone on your X-ray. Is my screen visible to all? Please confirm. Sorry, please. Just give me a minute, please. I'm trying to put up my screen. Just go back to the meeting. Okay, just let me give me a minute. I'm trying to pull out my screen. Now is my screen visible to all? Please let me know if it is visible. Okay. So now the intent is to reach this fusion zone. So the idea here is to penetrate through this area, fibrosity area, pass the fusion zone and engage our implant here. So how to go about this? The most important thing, step number one will be to understand the anatomy on the X-ray. Now, one of the most important X-ray, or probably the only X-ray you need for this, is a OPG X-ray and not a CBCT X-ray. But before I discuss how to read the OPG X-ray, I'm just putting up this image where you can now identify on the X-ray the fusion zone. Can you appreciate the fusion zone? This is formed by the fusion of lateral pterygoid plate to the distal part of the maxilla. If you see here very carefully, you will also be able to appreciate a depression behind the maxillary tuberosity, which is called as the hamular notch, and an extension over here from the medial pterygoid plate, which is called as the hamular process. And this now we are starting to identify on the X-ray. Earlier we discussed it on the skull, and right now we are discussing this on the X-ray. So far so good. Just let me know clear if it is clear so far, so I can tell you the trick on how to identify this and decide your angulation based on your OPG X-ray. Great. Okay, so this is what we intend to do. We wish to get our implant from here into the fusion zone. Okay, you can see one more time. Again, this is the fusion zone over here, formed by the distal part of the maxilla and the union of medial and lateral pterygoid plates. You can appreciate the hamular notch and you can appreciate the hamular process. Now the trick to identify this in the patient's mouth is to use the OPG X-ray. Now, whenever you are studying the OPG X-ray, you should start identifying. The landmarks which I am going to describe right now. So you start tracing the maxillary cells. Okay, so here you can appreciate tracing the maxillary cells. So first thing what we do is trace the maxillary cells and decide whether the case has easy or it is difficult. This is also okay. When there is appointment, this is cortical. This is the zone B. When you are appointment, this is cortical. But coming back to the pterygoid, once you have this, what you need to do is locate your fusion zone. Which is your connection with the distal part of my maxilla, and then reverse that we have already told you that this is 14 millimeters. So roughly from 7 millimeters, you should reverse and your implant. A lot of people want to do this because they don't do this kind of reverse technique because they know that they start from the CT and even before they start that outside. So one of the major tricks in India for pterygoid implant is to reverse land, which means we not land for the end point of the land for the start point. So again, I am showing you to find the fusion zone because it is 40 millimeters from 7 millimeters from a line, and this is your start point. If you think that you can randomly take any start point, people say this is of second or velocity, then there is a possibility you will have outside your and this is what commonly the mistake people do. How many of you perform this mistake of determining the start point correctly, being the important and then reaching the end point amazing is just I will go so far. Everyone of you has understood the anatomy. You understood the identification on the X-ray, and now you know how to plan the case. Now, one important thing during this planning is your treatment and template. I will just quickly put up regarding the treatment and template to all of you. So those of you who are already in the sessions, they know about the treatment planning template. But those of you who don't know about the treatment planning template, what we call as the TPT, I am putting in the chat box the video for the treatment planning template. So this template makes it very easy when you hold it against the OPG X-ray. Almost to 90%, it will determine the probable length you may need for your pterygoid implant. Now, whether you want to place a conventional or basal, the steps are remaining the same. This is the beauty of this protocol. Where with the same technique, same protocol, same process, they are planning the case, drilling, and if you're placing, you want to place conventional, you place conventional. If you want to place basal, you place basal. In the R-line system, the same drill allows you to place the basal as well as the two-piece CIH implant. So all those who are probably new and don't know about these terminologies, please refer to the R-line videos on my YouTube channel. So this same YouTube channel where I have shared the chat box right now, you will also get the videos on the R-line implant series, the CIH and the basic implants, where how with the one kit, one system, you are able to place both the two-piece conventional as well as the single-piece basal implants. Is it all good so far? Can we go ahead? Please let me know. So far, so good. All with me. Now it's going to get even more interesting. Great. Back to Dr. Sandeep. So now, once you have planned your case, the next thing which you need to pick up after your TPT is your C finder. The C finder is like a magical instrument which allows you to solve the anatomy in the pterygoid region without actually drilling away any bone. So here I am showing you the use of C finder. Here I am showing you the use of C finder and how to use the C finder in the patient's mouth. Wherein you have studied the anatomy, you know where in which direction you have to go based on your TPT and the other discussion we just made. And now with this hand instrument, you are attempting to reach in a buccal superiorly distal direction to reach the fusion zone. It's a blind procedure. Remember, it's a blind procedure like your intervitellar nerve block. So this instrument under LA, you will start piercing inside the patient's mucosa, palpating the mammilla process in this way. The beauty of this instrument is, and I may dare to say this on an open forum, that no other C finder or no other pterygioid will hold the direction for you the way you are seeing on the screen right now. See, a lot of pterygioid tabs are available in the market, you would, but you need to keep holding them because next time you have to go back to your hand, please change your drill, come back. If you give it to your patient, and then if you give it to your assistant, and if the assistant moves the C finder, you are gone. If you remove the C finder, then your purpose of scouting is gone. So you require an instrument which holds or kind of always, which only this kind of design which we have created a channel holding this direction for you is possible with the C finder. Along with the markings which correlate with the treatment planning calculation, you know the length you have penetrated. How many of you are now seeing that when you follow these steps, you are predictably going towards the pterygoid area, not damaging the bone, knowing the anatomy, and now moving towards the pterygoid. Okay. Now, the major question people ask me is, how many of you know that you can still follow all these processes and there is a possibility that you may not get the pterygoid region? Is it a possibility? So you have studied the anatomy, you have studied the OPG, you have planned the direction, and you go with C finder. But let's assume that you don't get or you don't hit the fusion zone. How many of you want to know what to do next? Just type me in the comment box. Sorry, the link किधर है please? Just give me a minute, please. I am wanting to show you what to do in case if you don't get the pterygoid, what to do, or if you don't get the fusion zone, what to do. Is everyone able to understand the step by step how to identify the structures on the skull, on the X-ray, and the direction? And now we are discussing the process. give me a minute, please. So till the time my team is helping me get to the link of what to do next, where we are going to give you a glimpse of rule of 7. So far, any queries, just let me know in the comment box, please. Any queries from the premium group members, please let me know. Definitely, we will give some additional advantage to you. But even otherwise, if there are doctors, so far, whatever we have covered. Yeah, so Dr. Jyoti is saying that on your OPG, the magnification is 1.25. On the treatment running template, it is written 1:1. So 1:1 is for the CT scan. So there are just, I will try to get the TPT now. There are 2 TPTs, madam. So one treatment planning template is for the OPG exercise. So if you're using planning with the OPG, you need to use the 1:25. And if you're using the other TPT, which is used on CPCT or CT scan, you need to use 1:1. The video of how to use the TPT I've already put up in the chat box. I request all of you to go through the TPT video, which will make it ultra clear. Still, if you have any doubts, we can always discuss it on the WhatsApp group. Correct, Jyoti madam, you got it?
Yes.
Right? Any other queries so far, please let me know. So Dr. Kalpana is asking, what is the use of large C finder in the kit? So madam, any hand instrument, like if you're doing rotary, you have all your hand instruments and you have rotary instruments. Similarly, over here, there is a first drill is the hand drill is the 2.0 and the second hand drill is the 2.5. Now, a lot of doctors who want to go meticulously, they want to first put the first hand drill, then they will put the 1.8 drill in the R-line kit. And if the bone is very dense, again, they will use the second hand drill or the hand drill, and then they will put the second drill. So those of you who want to go step by step, all your rotary instruments have been replaced with the hand instrument, which is called as the C finder or the cortical finder. I hope you have got this, Dr. Kalpana. Now here, I want to play this quick link, which is like almost like a 45 minutes. Of course, we cannot play the complete thing, but right now we have reached a point where we have already discussed understanding the anatomy, palpating the anatomy direction, and now going in the direction to locate the fusion zone with the C finder. But let's assume that you don't find the fusion zone with the C finder. Okay, so here, let me share my screen. Let me share my screen, please. Let's be here. Are you all able to see my screen? Now, this is the recording which is available. The 7.5 hours of recording on the pterygoid implant, zygomatic implant, now bypass, is available as the online tutorial. My team member is sharing the brochure for the same. I'm just playing a small glimpse from that for all of you to understand. Along with this recording, all of you will get, whoever is going for the recording, will get a complete step-by-step live video surgery where every step I'm explaining what is to be done, what is not to be done, and every rationale behind every step for the zygomatic implant, pterygoid, and the now bypass. This is applicable for the conventional as well as basal implants. To talk on to this, there is an entire webinar which was conducted earlier, recorded, and put up along with this video. There is a lot of queries related to the zygomatic implants and the innovative 2-hole zygoma implants, along with a bonus session on patient acquisition portal, is all grouped in and formed in a online tutorial, the brochure of which we have already are putting in the chat group. So let's get back to our topic, wherein you are trying to do the use the C finder, but you don't get the fusion zone. In that case, you need to use what is called as the rule of 7.
After you have got kind of 20 millimeter, or if something is going wrong, I am getting USD to come out.
Is this video audible? Please let me know if it is audible in the comment box. Discussing what exactly has to be done. So please let me know if the video content is audible to you so I can play it. Is it audible?
Shift your or after you enjoy your way more time. You shift your hand. So I have gone in the osteotomy. I am not getting a fusion zone. I don't come out of the osteotomy. I come halfway and I take my hand more buckle, almost 60-degree kind of a thing. When I say buckle, it's like proper buckle. Just a nankani. Almost as if you're going down almost 40-60 degree. Okay, see, this is 90 degree. Almost 60 degree. See, you are going your way. Yeah, you are going in this, like this. Okay, you come out halfway and take your hand almost 40 to 60 degree and go this way, because the idea was for medial pterygoid. You got it? Okay. So rule says that if, for example, you have started over here, okay. So first rule is you come out halfway. That's your second attempt. First attempt you did not get. You come out halfway. You take your hand or buckle almost 60 degree and you re-attempt with C finder. You are not allowed to pick up till you have managed with C finder, finding your edge point. So go in, come out, take 60 degree, try to hit again. Is that attempt one? No. If you get it, continue the rest of the steps. Towards the tip, but it can happen. Don't get it. Correct? In that case, you abort that osteotomy. जहाँ पे आपने कोशिश किया था, that side you abort it.
Right? So what I wanted to show you is the rule of 7. Of course, it's the rule of 7 itself is a 45 minutes discussion, which is beyond the scope of today's webinar. But to give you a glimpse of rule of 7, basically the rule of 7 explains you what to do if you go with the C finder and you don't get a pterygoid, how to make 6 more attempts, because one attempt is already done. So rule of 7 gives you 7 attempts for one pterygoid implant placement. So these rules I have accumulated. These rules will not find in any book. You will not find on any other webinars. This is purely from my experience of training so many doctors where probably the mistakes are happening, and I feel that इसमें ऐसा किया रहता तो हो जाता. So based on that, I have formulated 7 rules you should follow step by step in case if you are not able to hit the fusion zone with the फिर भी नहीं हुआ तो step 4, फिर भी नहीं हुआ तो step 5, फिर भी नहीं हुआ तो step 6 और step 6 नहीं हुआ तो rescue protocol, which is nothing but placing a wider implant. Let me quickly pull out my presentation to show you what is a rescue protocol. Okay, so as you see on the screen right now, in case the rule of 7 says, in case if you don't get anything, then you should be using a rescue protocol, which is using a wider and a longer implant, 7x12 or 7x14 implant, engaging the distal part of the maxillary sinus, you see this distal part of maxillary sinus and the distal part of the maxilla. So here you are engaging distal part of maxillary sinus and distal part of maxilla with a 7x14 or a 7x12 implant from your R-line kit. This is called as the rescue protocol, which is step number 7 in the rule of 7. A small glimpse of this rule, because some of you said the audio was not visible. My team members are uploading the video in the chat box also. Just kindly go through it. Detailed explanation of rule of 7 is very difficult, because that itself is a 45 minutes to 1 hour lecture of how to handle the situation if you go with the C finder and you don't hit the pterygoid. So that complete rule, everything we have compiled in our online tutorial, and my team member is sharing the link of the online tutorial. Those who are interested, please get in touch with them and they will happily help you out with the link. Along with that, the link contains the now bypass, Zygomatic innovative 2-hour technique, live recorded surgeries, and a webinar with question and answers on the Zygomatic technique. Okay, so that's regarding the rule of 7 for all of you. A small glimpse of the video of the rule is already put up. I strongly recommend you watch the video as soon as possible, because after the Zoom session, the chat box will get closed. So the video is put up. I'm just giving a 5-second break for all of you. Just download the video and keep it for going through the rule of 7. This is a small glimpse. This is not the actual complete rule. The rule of 7 is a good 45 minutes lecture by itself. So once download is done, please let me know. If you're done, we will move ahead. So just let me know if all of you have downloaded at least some glimpse of the rule of 7. And you please watch it later on. Please don't start watching it right now. You can watch it at leisure later on. Just download and keep it so that it doesn't go away from your chat box. Yes. My team member is putting up the brochure. For those of you who want the complete lecture on rule of 7 pterygoid zygoma, they are putting up the brochure. Just first page of the brochure is enough. And those of you who are interested can get in touch with them. Just put your contact number and the brochure. Great. So can we move ahead, please? Just let me know. In simplicity, the rule of 7 gives you 7 attempts to getting the zygomatic implant right. So a lot of you, you give up in just the first attempt, but that is not the case. I want all of you to know and understand that you have 7 attempts to get the zygomatic implant, the pterygoid implant correctly, and the rule of 7 gives you 7 attempts to get this right. So all of you should memorize and know about this rule of 7 so that you can attempt. If you have not got it in the first attempt, you can take 7 attempts to get your pterygoid implant right. Okay. So Dr. Sandeep has asked a very nice question. How can we confirm with the C finder that we have reached the fusion zone? Thank you, Dr. Sandeep, for asking this. So number 1, once you have matched the probable length with your treatment planning template, you will see in the fusion zone, when you're placing the C finder, you are falling short by around 3 to 4 millimeters. So let me put up the whiteboard so you understand this more correctly. Are you all able to see my whiteboard? Please let me know. Right? Now, if you are going, let's say you have the fusion zone over here. Okay. Okay. You want to go towards the fusion zone from your maxillary tuberosity. Now your treatment planning template has already given you the tentative length. So this is your maxillary tuberosity, this this is your fusion zone. From your treatment planning template, you already know that probably you're going to hit your fusion zone at around maybe let's say 20 millimeter or 23 millimeter or something like that. Now, when you're going with your C finder, which is a hand instrument, you will be able to penetrate up till with the hand strength the distal part of maxilla. At this spot, your hand instrument will kind of feel locked or it won't move ahead, which will be most likely 4 to 5 millimeters lesser than the length on your treatment planning template. So number one is the resistance which you got confirms that you are reaching the fusion zone. Let's say you are in the soft tissue or somewhere else, the patient will have some pain, minor bleeding, and you will not find any resistance. It's like your inferior alveolar nerve block. If your needle is not hitting the bone, you will not feel anything. You can keep going deeper, 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 which is another good effect, which is another advantage of TPT, because let's say your plan on the TPT, your pterygoid is 20 mm and you are going in 23, 26, 29, the bell should ring that something is going wrong. So number one is the resistance. Number two is you need to give a small tap on the C finder. Now, why you need to give a small tap on the C finder is so that you are rolling out any false positive. It is possible that there is some dense bone you are hitting and that is not the fusion zone. So when you tap on the fusion zone, apart from the tapping noise, is also eliminates any kind of false positive result, because only if you tap, the only very resistant zone over there is your fusion zone, which means that there are three ways of confirming, Dr. Sandeep, that you are in the fusion zone. One is the resistance, second is the TPT, and third is from the tapping noise in the fusion zone. How many of you found this really valuable and a deep insight? So even before you have touched your drill, so much information we already know: the direction, how to tap, rule of 7, and how to identify whether we are going correct. How many of you found this really informative and something unique you have never heard before? Do you all agree that when you know so much thing, then the things will become predictable? A lot of you people are just trying to, watch some random video or gather random information and trying to attempt pterygoid. You may end up doing it, but you will never develop the confidence to do it unless you follow this step-by-step protocol, know everything, the surgical anatomy, the radiographic anatomy, the direction, C finder, rule of C finder. When you use it, what you will get? Are these 6-7 steps confirmed to you so far? Tapping means you have to knock on the C finder. Okay, so if this is the C finder, let me show you the C finder. How many of you in this group already have the C finder? Can you write me in the comment box? With the hand. Initially, Dr. Sandeep, you will pierce with the hand. It's a sharp instrument. Once you use, you feel you have reached the fusion zone, you will give a gentle tap. So this is your C finder. How many of you already have, Dr. Kalpana, you already have the fusion, the C finder? Great. Will it perforate? No, it will not perforate. And that is the beauty, that because you get the resistance with the hand instrument, you are confirming even before the drilling that you have reached the fusion zone. I hope iPhone Red, you got the answer to your question. Anyone who has used the C finder and wants to give a quick feedback, please. Dr. Kalpana or anyone else who has used the C finder. Thank you, Dr. Deepika, for sharing that you are liking the instrument. Dr. Jyoti, yes. iPhone, yes. Great. So all those who have used it can understand the importance of this one instrument. Lot of people, if I want to play leather cricket, it is not possible that I don't have pads and I start playing leather cricket. It's not possible. So equipment will also play a very, very important role in getting the output from what you wish to do. Yes, Dr. Kalpana, it's very important. I cannot think about pterygoid anymore without this hand instrument. It makes it very predictable. Thank you, Raghuram. So those of you who want to have a quick glimpse on the C finder, my team member is putting a YouTube video on C finder. Do watch it, where more detailed steps of how to hold the C finder, where to tap, what should be your tapping pressure, and what to hear. You will get it exactly. Yes, it just gets fixed in the side. That is what. So in case you are not in the fusion zone, you will come to know. Otherwise what will happen is you will drill and you will keep messing up the bone, or you will put the implant and you will keep messing up the bone. Actually, the C finder is the key to your pterygoid region. A lot of people think that I have not got the fusion zone. With rotary, I will find it. They feel that if I have not done with drill, somehow the implant will go in the fusion zone. That is not going to happen. So all the 7 steps are there in this. So these 7 steps we are discussing about the C finder. So far we have discussed the 7 steps for reaching the pterygoid. We have not still come up to the pterygoid. And in those 7 steps, what mistakes you can do, the rule of 7 will cover you. So in all, you need to know 7 into 7 into 7 possibilities. So that makes it roughly 49 into 7, which is 343 possibilities of entering the pterygoid and the mistakes. And this is what makes it interesting and amazing. So just bookmark this link on C finder, and a lot of people have already used it. They have already confirmed it. They are kind of enjoying it. So those of you, I think, who are struggling with the pterygoid, one of the most valuable tip you can take from today's session is buy the C finder, because that will be a game changer. You will thank me for making you buy this instrument. I can vouch on this. Your life will change. If you're struggling with the pterygoid, this is the instrument you need, if you know everything else. Okay. Once you have predictably hit the C finder, the drilling remains a formality. Let me show you how. Let me show you why the C finder makes everything so easy. Are you all able to see my screen right now? Just let me know if my screen is visible to all. Is my screen visible to all? Please confirm it so I can move ahead. Now observe what we are doing next. So take the 1.8 drill, which is your first drill from your R-line kit. Remove the C finder and going into the channel created by the C finder with the drill. Just observe this very carefully, please, and see what is happening. I'll just play this again for all of you. Now, when you're observing, you see the trick to drilling in the pterygoid region is not to drill. If you've created a channel, all you need to do is go and practice inside the channel before you hit the pterygoid zone. A lot of the people, they start drilling again. Now, if you start drilling directly, what will happen is you can create a new channel. So the trick in drilling in the pterygoid region is not to drill. How many of you knew this? Just see the video again and just see what is happening. The trick in drilling in the pterygoid region is not to start drilling. Enter the channel, practice the direction. See this. I'm practicing, and then hit on the fusion zone. When the drill comes out, you see the clean white bone. That is another tip you need to understand. So 3 things will tell you. One is the resistance, second is the clean white bone, and third is your confirmation of the direction, because there will be very minimal bleeding from your osteotomy. How many of you found this thing revolutionary, something you would have never see? If I just show you the thing in real time without telling, you will not even come to know that this is happening. But now that you know that the trick after using the C finder to drill in the pterygoid region is not to drill. How many of you found that this makes big logical sense to all of you in the way you're going to work next time? So the trick in finding the fusion zone is to find the start point, not the end point. The trick to drilling in the pterygoid is to not drill. And when you finally the fusion zone, observe the drill for the bone as well as your resistance which you have got, and match the length which you have got with the length on the TPT. Does this make it predictable now? Are you able to understand the predictability of the procedure now? Just type predictable if you have heard it from the start and understood each and every point in detail. Now imagine you're with me just for the past 20-25 minutes, but there is a complete 7.5 hours of more in-depth video on this. Do you agree that that will make your life very easy with the pterygoid? Another 7.5 hours of deeper learning into just the technique of pterygoids. So Dr. Sheikh, opening the flap is one of the rescue protocols. So I told you already that there are a rule of 7. You need to make 7 attempts. And after the 7th attempt, still if you don't find the pterygoid and you don't wish to put the rescue protocol, in that case, you have to open the flap. Now the flap design is very, very unique in the pterygoid region, because if you don't create a proper flap and if the bone is soft, sinus is pneumatized, 99% you will end up with the oroenteral fistula. So the design of the flap, which is mentioned in the book, you should follow it to the dot. If you make an error in the distalmost incision and end up in the sinus, I can guarantee you, you will make a oroenteral fistula. So don't think about any other flap design apart from what is mentioned in the book, in case you want to open a flap in a resolved jaw, especially in the pterygoid. If it's like a good jaw, nothing will happen. But in the resolved jaw, if you are opening a flap, putting a vertical releasing incision near the pterygoid, you need to be absolutely bang on. I hope, Dr. Sheikh, you got your answer. And sir, in extraction socket of upper 8, do pterygoid is difficult. Sir, in fact, in the extraction socket of 8, the pterygoid will become very easy. Just go in the palatal route and use diameter 5.5. Lot of us, now this is another big trick and tip you need to remember. We take care about the height, length and the width, which is the third dimension, but we forget the fourth dimension, which is the density of the bone, the quality of the bone, which means you can be in the perfect area, but if you have selected a smaller diameter, your implant after reaching there will not get torque. It means you have put a shorter or a less wider implant in a soft bone. The thing is, you should be putting a wider diameter implant when the bone is softer. In an extraction socket, where you have already lost a lot of bone, there is an extraction edge, a cancellous bone, extraction site. The trick is to use directly a 5.5 implant. As we already covered in the start of this lecture, you may end up hitting the palatine bone, which is okay because you will get your distal anchorage point. So whether you are in the pterygoid or palatine bone, it will not matter. Your purpose of creating a distal anchorage will be served. Great. So iPhone, I hope you are clear with your, yes, great. Your name please, sir, Dr. iPhone. Where are you from and is this like your first session? I hope others are also Dr. Jugal. Hi. Hi, Dr. Jugal. So I hope other doctors also, Vishal Soni, Nikhil Patel, Nag Milya, Dr. Gaurav, Dr. Jyoti, Dr. Anita, Dr. Anil Kumar, Dr. Anuman, Dr. Deepika, Neetu, Dr. Shrikant, Sandeep, Vivek, Johnny James, Prerna, Dr. Mashtan, Dr. Muthu, Dr. Sheikh, Yushkam. I hope you are with me, Dr. Vivek Chaudhary, Dr. Shrikant. I hope you are getting all this and it's helping you improve your game. Hello, Dr. Kapil. Hi. Great, Dr. Jugal. Yeah, you have done our residency. I hope this is adding value to what you have already learned. Dr. Jugal, if you can give a quick feedback about your residency program also. There are some doctors who keep asking us what has been your experience, because I remember interacting with you, it was amazing. But if you don't mind to share your quick experience. Dr. Kalpana is asking, in case of impacted 8, pterygoid be placed from 7 region, it will depend on the location of the 8. If your 8 is very much close to the tuberosity, then I would strongly recommend you extract it. But if your 8 is kind of obstructing your direction, or you're drilling towards the pterygoid, then you have no option but to remove the impacted 8. Most likely after the removal, your pterygoid may or may not become difficult, and that is why you may also have to plan the zygomatic implant. So this will be case specific and skill specific in your particular situation. Yes, Dr. Yoshakam, I know we need a longer session. So 7.5 hours of e-learning program is already available, and you can simply watch it at your convenience, because 7.5 hour lecturing is next to impossible. The minutest of details on not only the pterygoid, the zygomatic, nerve bypass, along with the live surgery is there. So all of you who are interested in more detail, please go through the 7.5 hour lecture. It will be a life-changing session for you all. I can assure you that. So Dr. Rutuja has written, I have attended Dr. Rohan sir's lecture on pterygoid and zygoma. Lecture was complete eye-opener. Thank you, madam. And 5 hours of lecture helped me a lot in my pterygoid implant practice. Thank you, Dr. Rutuja, for giving a wonderful testimony of all the hard work we are putting in. So Dr. Jugal is sharing his experience regarding the residency program. So residency was awesome. I have placed 50 implants, hard cases. I'm very happy to do Jugal. One thing I want to tell about Dr. Jugal to everyone, he is very focused. From the day I met him, any instruction you give him, he is going to follow it, and he is very meticulous in the planning. He is not like trying to cut corners, and I'm seeing his cases evolving over the time. So Dr. Jugal, let's type MPTY to you, Dr. Jugal. More power to you. Let's type MPTY for Dr. Jugal, all of us, and I hope that this journey gets further accelerated. And thank you for sharing the wonderful feedback on the residency program. So Dr. Unaya is writing, I have attended master class on pterygoid, zygoma and nerve bypass. It was very clear. Thank you, madam. But Dr. Unaya, I hope you agree to the fact that every session we discuss new points. It is not that we are just discussing the same old things again and again. And I'm sure you will agree that every session you are getting more deeper insights into this vast topic, because pterygoid and zygoma, they are such vast topics. I can speak for 2 days and still some content will be left over. So I hope you agree that, yes, Dr. Shrikant, I'm very happy that you are doing, after attending the class, you are doing with confidence. That's great. Let me just pull out some more questions. Are there any? Anyone who would want to just, get unmuted and share any question related to the pterygoid implant from whatever we have covered so far, please let me know. So Dr. Jyoti. Dr. Jyoti, I am trying to download the file. If you can just share it on the WhatsApp group, it will be easier for me. Dr. Jyoti, please share your images on the WhatsApp, please. You can DM it to me, or if you're a premium group member, you can put it on the premium inner circle also. So those of you who are keen on joining our premium membership also, my team members are sharing the link for the premium. You can join the inner circle premium also, where we are sharing some videos and discussing them almost in a week. We share 1 to 2 videos and go deeper. Either Dr. Sumit or me sharing each and every video in detail and discussing related to that. Yes, Dr. Onair, thank you for confirming.
Thank you,
Dr. Jyoti. Thank you. Dr. Jyoti, because you're already unmuted, is there any question you would want to ask related to the things we have already discussed?
sir. Actually, this case which I attempted, no, I got the fusion zone, and then I drilled there. Then I got a slight dip, and then I went through it. It got engaged nicely, and the dull tap which you checked for the torque also I got. But on X-ray when I saw, I found it little short. So little I thought that one more thread should have gone inside. So, but I was fearing if I still do it, that retromolar last portion may fracture. So I should have come out and then again gone inside.
No, madam. What you should do is when you get a very high torque, that's about it. Because when you're talking about a fusion zone, it is not a line, it is a zone. So what happens, sometimes your implant has penetrated complete, sometimes it is halfway, and in some cases, when the pore quality is poor, you will go full length. But as long as you have penetrated the fusion zone and you have full torque, you should ignore the X-ray and remain with the clinical finding.
Okay, sir. Okay, sir.
Okay, so I hope this tip also was very valuable to you. Otherwise, you would have, if you remove your implant, which is good, and try to place again or do something over there, you will lose the good torque because the implant is diameter 3.5. So removing out, you will churn bone, you will make it 4. By putting in, you will make it 4.5, you will lose your torque. So never do it if you have got good torque.
Okay, sir. Thank you. So one more thing can I ask?
Yes, sure.
Yes, I attempted one buccal nerve bypass. In that, when I was going buccally, the buccal bone, it was quite hard. It fractured. So that means, and the size I had used was 4.2. I should have used 3.5 only for the buccal nerve first, or is there a thinner R-line BCS implant?
Madam, can I scold you in the open forum?
Yes.
Have you read the book, madam? In the book, it is clearly mentioned for buccal bypass diameter 3.5.
Yeah.
So why you attempted with 4.2? Already the protocols and giving users have to follow it, madam.
Yeah.
Okay. So yes, but you are you should have, and also there is a possibility you have over tilted. So what has happened is you have come too much superficially on the buccal side. So what happens is we are very scared of hitting the nerve. So you keep tilting that you are almost out too horizontally. You need also. So these two things could be the reason. But anyways, we are not discussing now bypass. We will keep it for some other day where hopefully we will be able to give you deeper insights. For those of you who want to accelerate the journey, already the 7.5 hours content I have shared it. You can just go through it and you don't need to, cherry pick the information like this. Right, madam? Nice, madam. Good. All the best, madam. Good luck to you. All the best.
Thank you.
Yes, so Dr. Mandar, I think, no, you have put up, okay, this is the case, okay, no problem. But madam, you have done let me tell you, Dr. Jyoti, you have done a nice job. I think you enjoyed the R-line system and you have done a very, right? So if I can just, I don't know if you have,
Second X-ray which I said, so I attempted in the canine region, premolar region, and even the pterygoid region. And C-finder helped me in the canine region also, and other regions also to know the length perfectly.
Right. Yeah, it's very useful. That is what. So a lot of people I see they keep struggling, but I have seen the biggest of names using the C-finder they have taken from, and the game has changed. So I think C-finder is almost, if you are like thinking about pterygoid, it's almost like something you should have it. And the rest of the thing it will work by default. Now I'm putting up with your permission the X-ray also which you have shared.
Yes, sir.
So this is your X-ray. Am I correct? You are able to see.
Yes, sir. Yes, sir.
So this is perfect, madam. Nothing to worry. You are perfectly. If you see now, all of you, let's appreciate Dr. Jyoti for beautifully executing such a nice resolved maxillary sinus case. And if you see here, this is the tracing of the sinus.
Yeah.
Okay. This is the perfect in the fusion zone. You can see the pterygoid. You can see the nasal implant. Only thing, madam, if I can critically, if you allow me to comment, you should have added one 5.5 implant in the sinus area, which means otherwise your distance between this implant and this implant is too much. These implants are isoelastic. So the rule for planning the segment cases, I want to tell all of you just make a screenshot of this image which is there right now. Just make a quick screenshot and let me know when you're ready to know the rule of planning for segment cases. How many of you are ready? Just if you have done the screenshot and ready, please let me know if you all are with me. The rule for planning for segment cases, you have to plan till 8. How? So if 4, 5, 6, 7 are missing, you have to count 4, 5, 6, 7, 8. So I need 5 implants. 5 is ideal, 4 is okay, 3 is risky. So if group number 4, 5, 6, 7 are missing, you need to count till 8. 4, 5, 6, 7, 8. Assuming 5 implants. 5 is ideal, 4 is okay, 3 is risky. So to plan any segment case, count till 8. So if let's say from canine everything is missing, so 3, 4, 5, 6, 7, 8. I need 6 implants. 5 is okay, 4 becomes risky. How many of you found this simple tip useful for you to planning the number of implants needed for a segment case? And Dr. Jyoti, just quickly, if you can also tell your experience with, please don't name any other companies, that is not the purpose of asking you, but if you have used any other company versus R-Line as a user, what advantage, disadvantage you found, if you can share, please let the group people know. We are all one community.
Actually, R-Line implants are very handy and useful to bend. I tried bending this 3.5 and I could do it by seeing just your videos, and I was little worried, but other implant systems, it is very difficult to bend, and the threadings are very sharp. So with one drill only, the things work very well. And as per whatever is written in the book, word to word, tip to tip, if we follow, then we should not find any problem. And the first attempt when I did, I had not read it completely, so that is why I went wrong. But now 2 days, whole day, I sat and read the book, and as per that, this case went very smooth. So I like to follow one system whole and soul, because you don't waver from the concept, whatever has been taught. I don't like to jump from one system to another system. I earlier I have done conventional implants. The other side of this patient, I have done this 7 years back. But on the right side, I had not given him any other processes, because I was worried about the sinus floor and all. And the patient didn't want augmentation and all that. I was thinking that we will need to put zygoma for this case. But when I attended your course, the Pterifìgoideak helped me a lot, and this canine premolar and the second premolar also, I could add the basal implants. One more, I didn't dare to put, this was done yesterday only. I welded till the pterygoid, and I have called the patient tomorrow again. So I wanted to show this how, means I was little skeptical for this segmental case. So now that I am following basal, I follow only R-Line. And it is, it has solutions for everything. You have the MU implants also, you have the cementable, like the single piece implants, you have CIH, and you have DSI. So once you have everything, the armamentarium, then any kind of case you can do. You need not just keep look out for any other implant system or anything like that. And be dedicated to one system. It will give you benefits and benefits, nothing like it. So R-Line has given me whatever I wanted, whatever cases I was leaving away, or whatever I couldn't do, and I used to, patient used to go away. So instead of that, I can do all these basal implant procedures and give them the processes, and patients are also okay, like they're ready to it. The welding procedure also I feared. I went ahead with two implants welding first, then 3 implants, and this case four implants totally. So it was nice. So I totally believe Arline gives you all the solutions in all the cases.
Great, great. Madam, one very important question on behalf of everyone. How much is the revenue jump in your practice? I'm not talking numbers, maybe you can say 10%, 20%, 30%. I think that is the crux of the game.
Yes, I can assure you that if you are doing implant practice and you see to it that every patient is benefited. See, I do patients for the poorest of the poor and the richest of the richest. But technically, if we follow everything from X, just as you had mentioned, it really works up to 5X. And patient definitely now, this case which I told you, now more than 7 years, the patient is happily eating, chewing.
Wow.
No maintaining also. So that this case which I should have done 7 years back, now I have done it because I didn't know what to do with these poor resolved rich cases. I didn't have any option, though there were other systems in the market. Just because you explained all the things so clearly, tip wise, system wise, and anytime I have the answers from you. So it really made a lot of difference.
And that is what I say always. You should have a system. The result should be byproduct. What happens is people focus too much on the result. But if you just keep refining your system, so you read the book, you have probably done the course.
I took 1 week to read the book.
Yeah, so if you have refined your system, the result is a byproduct. Because you know what you are supposed to do, then result is a byproduct. So thank you, madam, for sharing your feedback with us, and more power to you. Let us type MPTY for madam, and let us also welcome one of our Arline mentors, Dr. Sumit sir, and Dr. Pankaj. Hi, nice to see you also. And Dr. Sumit, if I'm audible to you, and if you can unmute yourself, please. So, Dr.
Yes, sir.
Sumit,
good afternoon, sir.
Yes, good afternoon, Dr. Sumit. Nice to
Yes,
see
sir.
such a busy practitioner. But I want you to probably answer one question on the behalf of everyone. So, just if you can, I just put up a question to all of you. To Sumit sir.
Yes, sir.
So, I have got one question from the Inner Circle Premium Group.
Yes,
sir. Doing buccal or lingual bypass, if accidentally I hit the nerve, does it feel soft or rock solid? So please answer the question from Dr. Kundal Barwa. He's asking what do you feel exactly if you hit the nerve?
Sir, first of all, whenever we are doing nerve bypass, we are always doing it under infiltration. So when we are, if we have given block, then one should not be attempting nerve bypass in the initial cases. So first thing first is that always do nerve bypass under infiltration. That is the first thing. Why? Because when we will approach the nerve, either by lingual or whether we are doing buccal, whatever we are bypass we are doing, if we are encroaching the nerve, the patient will immediately tell us that some pain is there, and immediately you should stop at that point. But suppose if we are, somehow if we are, having a bad day, we have given, instead of infiltration, we have given block, and we have gone in the wrong direction. So immediately, first thing, because there is an artery above the nerve. So whenever you will hit into the, that capsule which contains both the artery and the nerve, so first you will get some bleeding, immediate extra bleeding you will get, which is not normal. And second thing is that if you go, if you going to damage the nerve only, then it will be absolutely a soft thing. It is not going to be hard. So the best thing is to avoid all this would be to do the case under infiltration.
Perfect. Thank you, Dr. Sumit.
Thank you,
I hope, Dr. Kundal, you are happy and you got your answer. And let us thank Dr. Sumit for joining us from his busy schedule and answering such wonderfully. I hope, Dr. Kundal, you got your answer. So I think with this, a lot of queries related to the pterygoid are already covered. And if all of you want, we can have a very short discussion. Of course, today we don't want to overlengthen today's session. Some of the things I want to let you know before I end is, one is the introduction of the premium group, because there are a lot of doctors who want the continuous assistance in their cases, and the premium group has 4 mentors along with Dr. Subit sir, myself, Dr. Chetan and Dr. Saili, who are helping you continuously for your cases as and when you want. We have certain sessions which are specific to the inner circle premium group, and for the premium members we also have additional benefit of answering or taking up their questions first during our live sessions. So those of you who want to join the premium group, you are welcome. The link we are posting again for the benefit of all. On joining, you also get complimentary 6 webinars like this, which will further enhance you or help you get in par with all of us. So that's regarding the announcement for the inner circle premium. The other repeat announcement for people who have just joined is the launch of the 7.5 hours deep learning session on online. It's an online version, so you can watch it whenever you want from the comfort of your home, which is on a detailed session on not only the pterygoid, double pterygoid, trans-sinus, what to do if you don't get it, rescue protocols, the zygomatic implants, and the nerve bypass, along with the live recorded surgery and the Q&A session. So that's another update. The next update is that our next course dates 5, 6, 7 July. We have the upcoming 3-day program. Now this program will be very unique, because in this program we are going to discuss extensively about the multi-unit implants. So far we have already discussed in most of our programs the cement retained, but this program will have special emphasis on discussions on screw retained solutions with basal implants, that is the BCS as well as QoS, the details of which my staff will post very soon. Now, before we move ahead, I ask my team members to open up the inner circle 1 and 2, so that all of you can quickly share your 3 key learnings for today's session, and then we can discuss one more last but very important game-changing tip for all of you related to the pterygoid implant. So how many of you are ready for it? Just let me know. And before that, I request all of you to share in the inner circle 1 and 2 your 3 key learnings, and then I will give you the master trick which has not been discussed so far in this webinar regarding the pterygoid, which will also now kind of introduce you into the zygomatic implant. So let's get ready for it. We still have a couple of minutes. So before that, I request all of you to share the reason of sharing 3 key learnings is some, probably some points you have noted, you will put it down, some points, some other doctors noted. So you have a summary of some points, and it really refreshes each and every point. And in case you missed out on some point, you will get into it. So the idea of putting up 3 key learning always is to re-emphasize what we have learned so that it is not washed away. So I'll take a 10-second or a 15-second break. Before I come back, I would request all of you to, in the inner circle 1 or 2. Now 1 and 2 members, please don't join both the groups. It is futile. And in case any of our team member finds you in both the groups, then we may have to exit you from both the groups for not following the rules from our end. So just be in one of the groups. In case by mistake you entered both the groups, please exit any one group and remain only in one group. Secondly, right now I request all of you to just put down your 3 key learnings. And after this, we will be discussing one very major factor regarding the planning of the maxillary cases related to the pterygoid and zygoma. So I'm just taking a 5-second break so that you all can put up your 3 key learnings in the inner circle 1 or 2 group. It's amazing to go through the 3 key learnings. Such informative points all of you have noted. Perfect. Dr. Shrikant, you have hit the hammer on the nail. Thank you for putting your 3 key points. Please put up your points in the inner circle group so that it remains as a reference. Please don't put it in the chat over here. Please request all of you to just put it in the inner circle 1, 2 or premium group, whichever group member you are, so that it remains there. And even after the session, you can just brush through it. And if you missed any point, you can just go through it. Perfect. Dr. Jyoti, reverse planning is very essential. Dr. Swapnil, nice to see you are there almost in all the sessions. 82329, torque is important. Perfect. Dr. Sandeep, reverse planning, perfect. Jade Advanced Dental, rule of 7, C finder, reverse planning. Great. So let us now also in the next 10 seconds, quickly just finish this so we can start with one very important tip regarding the planning related to the pterygoid and the zygoma. Dr. Anita, key learning, palatine bone engagement, 4th dimension density, perfect. Dr. Shrikant, always under infiltration, perfect. Rule of 7, TPT, rule of C finder, correct. Dr. Raman, Dr. Meena Madam, point and direction, that's very important. Dr. Narendra, rule of 7, feeling of resistance, amazing. I think all of you have really grasped a lot. I'm very happy to see such a wonderful interaction and hope the step-by-step is getting clear to you all. So just I need a small quick feedback from you all that if before the session you were 0, let's assume you are not 0, but let's say you're on a scale of 0 before the session related to pterygoid. Right now, by just attending this session, how much would you rank yourself in terms of knowledge related to the pterygoid? What would you overall rate yourself just half an hour prior? This is the importance of these webinars, if all of you can understand. How much knowledge you have gained. I'm seeing these points. It's really amazing. Such in-depth points, never ever they are discussed in the books or in certain webinars I've seen. Amazing. Great, great. So 40 to 50% improvement, 9, 8 out of 10, rule of 7, great. So such wonderful insights is really going to change your game. Anyone who is going through the 7.5 hour session, trust me, he is never going to ask a doubt related to the pterygoid to anyone. That is how crystal clear it will become. 7.5 hours dedicated only to pterygoid, zygomatic and nerve bypass. Never ever in any literature, in any history, you will find such valuable content, totally clinical oriented. Thank you, Dr. Jugal. Thank you, everyone. Now let us, how many of you are ready for the planning and the most important tip, because a lot of you get confused with the CBCT and OPG and all those things. How many of you are ready for this most important thing related to the planning? Just let me know if my whiteboard is visible to all of you and if you are ready. Now, when it comes to the pterygoid implant or the zygomatic implant, what you need to do is pull out any OPG. And the first thing you need to do, which I keep telling always, just keep it, is to plan the or trace the sinus. Divide the maxilla into 3 zones. Zone A, this is your zone A, which I am marking in this pink color. This is your zone. This is zone A. which I'm marking in the pink color, which is ahead of the sinus. Zone B, which is below the sinus. And zone C is your pterygoid. Is everyone clear with this much? Please let me know if everyone is clear with this much. So to repeat on a OPG X-ray, is everyone able to see the OPG X-ray? Okay. If I mark the sinus over here, this is zone A. So what I'm marking in yellow right now is your zone A. What I'm marking or what is below the sinus is your zone B, marked in orange. And what I'm marking in blue is your pterygoid. So maxilla for all practical purposes is divided into zone A, zone B, and zone C. Anything ahead of the sinus is zone A, anything below the sinus is zone B, and anything behind the sinus or distal of the sinus is zone C. So far, so clear to all of you. Just let me know clear in the comment box. And now if you understood this, with this one simple thing, you will know whether your case requires a zygoma or doesn't require a zygoma. If your zone A extends till the second premolar, you never require a zygomatic implant. If your zone A extends till the second premolar, you don't require a zygomatic implant. However, if your zone A is shortened by the pneumatization of the maxillary sinus medially, which means in short, your zone B has extended up till the first premolar or canine. In that case, you will compulsory need a zygomatic implant. Otherwise, the distance between your pterygoid implant and canine implant will be too large. The AP distance between your canine and the pterygoid will become too large. So in cases where the zone A extends up till the canine, that case will require zygomatic implant. How many of you understood the indication of zygomatic implant? And how many of you found this one of the simplest way to plan whether you require a zygomatic implant or you don't require a zygomatic implant? Was this simple? Just let me know simple. How many of you found this trick amazingly easy and informative? Yes, Dr. Jugal, you're right. Remember only premolar, remember classification zone A, B, C. Perfect. Great. Great. Thank you so much, all of you. And I will like to take one final question from any of you members who have attended this session. You can ask me to unmute you or type your question. And let's end with this final question related to the pterygoid. I think zygoma, if all of you are keen and you tell me, we can keep a separate session. Just let me know your inputs. Today, inner circle will remain locked after this session because we've had our interaction today. So any one of you feels that needs any, yes, Dr. Srikanth, you have a question related to the welder. Can we unmute you? It will be better. Dr. Srikanth, can we unmute you?
Yes, sir.
Yeah,
Am I
yeah.
audible, sir?
Yeah, you're audible. Dr. Srikanth, please go ahead.
Last week, sir, I shared one case where I was not able to weld one implant. It was wire was not adapted properly. So that implant is still showing some space, say about 1.5 millimeter. So should I add some more part of wire inside that gap and try to weld, or should I make a bridge directly and splint it with the cement only?
Super question. Thank you for asking, Dr. Srikanth. So what Dr. Srikanth is saying, so let's say this is the implant and he's done the welding in couple of adjacent implants, but for some reason he's missed out on one implant. Am I correct, Dr. Srikanth? Is this your question?
Yes, sir. Yes, sir.
Yeah. So what has happened is, let's say 4 or 5 implants, whatever 6 implants you have placed, you've done welding here, you've done welding here. by mistake, this implant, you have skipped the welding and you welded here. Now, sir's question is whether I should do something to get this wire into the welding. Now, one thing is, Dr. Srikanth, if your wire is adapted very closely to the existing implant, you will be easily able to do it, and that solves your problem. If there is a lot of space and your implant is really rigid and you're not able to get it close to the wire, then it makes sense to add one more wire between them and then weld all of them together. That's trick number 2. Let's assume that you're still not able to do it. Then what you'll have to do is, instead of using an acrylic prosthesis, you will require some kind of a metal splinting in your prosthesis, which will, when you cement it with over your existing implants, create the rigidity in the framework, not allowing this implant to become mobile. Also, the fact that if this implant is a KOS implant, you can simply skip this step completely because your rigid implant will take care of itself with your other adjacent prosthesis. But if it's a BCS implant, you need to compulsorily create some kind of splinting, either with the wiring or with your prosthesis with a small metal frame inside.
Got it, sir. Got
Dr.
it.
Srikanth,
Thank you very much, sir.
so
Yes,
once
sir.
you understand the concept, see, like for example, this kind of a situation I have never encountered, but because the concepts are clear, automatically, if your concepts are clear, you will be able to formulate what exactly is required in that situation. So BCS implant, isoelastic implant requires splinting. As simple as that. There is no second rule to this rule.
Yes, sir. Got it, sir.
Fine. Great. So thank you very much, all of you, for attending this session. I hope it has got immense value to all of you. And we'll soon announce our next session with Dr. Sumit sir. Sumit sir will be speaking about various tips and tricks related to the prosthetics techs. Am I correct, Dr. Sumit?
Yes, sir.
Yes, sir.
Yes, sir.
So, Dr. Sumit, can you just give a small, quick gist about what you're going to cover in your inner circle session, so that people who are keen can join you when you are giving the webinar?
Oh, okay, sir. Sir, this is the topic will be the prosthetic aspects on tilted implantology using R-line implants. So I'll be talking about the basic treatment plan, when how to manage the space prosthetically, in what spaces we should go for which type of processes, how to manage the angles, and the various types of availability of materials which are there with the lab. In which case should we go for which material, and in sectional cases how we can manage sometimes without multi-unit also. And there are and in short something related to occlusion as well.
Super,
Yeah.
super. I remember, Dr. Sumit, your lecture, I had learned a lot last time, and I'm
Thank you,
really
sir.
excited and looking forward to your lecture in the next week or so, whenever we announce it.
Yes,
So
sir.
thank
Yes,
you
sir.
guys, and hope to see all of you in that session. And Dr. Jugal, your query on retrievable prosthesis with MU, Dr. Sumit will be covering in the next session.
Yes,
So
sir. I'll
thank you
cover.
very much, all of you. More power to you. Till next time, thank you very much. Goodbye, guys.